we are going to show laparoscopic cholecystectomy. This patient had symptomatic gallstones, for which we are going to do the conventional laparoscopic cholecystectomy. We introduce venous needle and pneumoperitoneum is created. The pressure is 14 millimeters of mercury. We insert venous needle and the camera trocar about 3 to 4 centimeter above the umbilicus. So the combination of supraumbilical port and a 30-degree telescope gives excellent view to the callus triangle. You can see the entire course of the common bile duct before starting the dissection. That is the main advantage. Once the camera port is introduced, then we have to raise the head end of the patient, and the right side of the patient is also raised so that we'll have a better exposure to the callus triangle. And with the guidance of telescope, we are introducing the epigastric 10 mm port. This is going to be the right hand working port, and this is going to be used for specimen extraction. The level of insertion of the epigastric port is, it should enter onto the right of the falciform ligament, and it should enter below the inferior margin of the liver. And once it is done, then we are going to insert the left hand working port, which is 5 mm. This is placed at the level of the fundus of the gallbladder, again just below the inferior bar of the liver. And finally, we are introducing the fourth port. This is somewhere at the right anterior axillary line, just above the ascending colon and hepatic flexor. So it should enter above the anterior to the colon. And now we have introduced all the 4 ports. So the atraumatic grasper is the left hand instrument, and the Maryland forceps is the right hand instrument. The fundus is grasped with the grasper, and it is retracted cranially. The fundus of the gallbladder is retracted cranially. And the first step for actually starting the dissection is to identify few landmarks. One is, you can see the course of the bile duct, and other landmark which you can appreciate in most of the cases is ruvius sulcus. So once you identify the ruvius sulcus, you have to stay anterior to the ruvius sulcus. Then we actually start the dissection. Basically, we have to release the peritoneum. Basically, we have to incise and release the peritoneum posteriorly, then anteriorly. Then gradually you can deepen it. And while doing this dissection, you have to stay on the gallbladder, and you should not, normally that there is a tendency to go and work towards the hilum of the liver, but you should make sure that we are going away from the CBD, common hepatic duct, and your dissection should go and it should follow the gallbladder wall. So we have to start the dissection at the cystic duct infundibulum junction. Worried, we should not try to expose the cystic duct and common bile duct junction, because if you use any diathermy, any energy at the cystic duct, common bile duct junction, it can cause injury to the common hepatic duct or a common bile duct. So you always try to identify the infundibulum cystic duct junction and try to dissect at the same level in order to create a window. So use a brief diathermy, lift the tissue, apply a brief monopolar diathermy. The diathermy is used in the coagulation mode. You can appreciate the cystic lymph node, and whenever you are able to, as a node which is cystic node, you should stay anterior to the cystic node so that you will not be injuring the common hepatic duct, and you will not be injuring the other vital structures like right hepatic artery also. Sometimes the right hepatic artery will be traveling inside the callus triangle. It will form a loop in the callus triangle, which you have to be very careful. So you can see a window is created. A good window just behind the cystic duct is created. Now we are trying to dissect the cystic artery. So you just follow the gallbladder. Whenever you are dissecting the gallbladder, just follow the gallbladder. So you should see whether any posterior branch of the cystic artery is there or not, and you should make sure that you are not dealing with any anatomical variations while doing the dissection. So you can appreciate the cystic artery is getting dissected. So combination of anterior and posterior dissection helps in identifying the critical view of safety. That means you have to lift the at least 1/3 of the gallbladder from its bed, and once it is done, you should see only 2 structures entering the hilum, The one is cystic artery, the other one is cystic duct. So we normally use 3 clips to each structures, 2 clips towards the patient and 1 clip towards the specimen with adequate gap between the second and third clip. You can see the course of the cystic duct, and whenever you are dividing this structure in the Kailash triangle, always divide the cystic artery first before actually dividing the cystic duct. We can appreciate on vessel which is traveling parallel to the gallbladder. So whenever you see any vessel like this, you should follow it until you are able to see whether it is going towards the gallbladder or towards the liver. So if it goes towards the gallbladder, then you can clip it and divide. If it goes into the liver, then you can leave it without dividing it. And a good traction and counter traction is very important in any laparoscopic surgery, especially in gallbladder surgery, while separating the gallbladder from the liver bed. So right side, left side and posterior dissection, these 3 combinations will help you in getting the gallbladder lifted away from its bed. You can appreciate a large vein which is coursing in the middle of the gallbladder fossa. If it bleeds, it will bleed profusely. Especially when you relax the traction, it will bleed profusely. So this bleeding is difficult to control with diathermy. Sometimes you may need to use sutures to control it. As you go towards the fundus, you have to tell the assistant who is grasping the fundus of the gallbladder to relax it and to bring the gallbladder down, so that you'll have a better exposure to get the gallbladder away. You can appreciate this vein which is very large, and normally it goes deeper to the cystic plate. You can see the entire course of the vein. Sometimes you'll have very little fibroareolar tissue between the gallbladder and liver. In these cases, you have to go very slowly, catch nicely with the left hand, give nice traction and try to expose the areolar tissue before actually dividing the structures. Nicely, gallbladder dissection is progressing, and this will be like almost like a final stage. Before actually completely dividing the gallbladder from its bed, you have to make sure that the complete hemostasis is achieved, because once the gallbladder is totally released from the liver, then the cranial traction of the liver is not possible. The gallbladder can be extracted in 2 ways, either directly through 10 mm port, or you can use an endo bag to retrieve it. Whenever you are dilating the epigastric port, you have to close it by using port closer needle. And finally, if you want to give thorough wash, you can give thorough wash and you can do a final check before actually deflating. Normally, there is no need to place drainage tube, but if you are operating infected cases, we use a drain before actually deflating the pneumoperitoneum. Thank you very much.